Ladies and gentlemen, welcome to this exercise number 5 about stents for coronary arteries. So the invention of stents comes with a disease that is called angina pectoris, which is similar in symptoms to a heart attack. It's a burning pain in the chest. You're slowed down immediately and always comes in the environment of stressful situations. The reason for that is that there's either narrowed blood vessels by obstruction or spasms that the coronary arteries contract, and therefore we suffer from an hypoxia of the heart muscle. There are some general treatments like taking drugs, mainly by an inhaler and you inhale, and there is TNT, that explosive that is in there as aerosol, and if you take it, it goes to the blood vessels and they are dilated and your blood pressure significantly drops. However, this is not against the root cause of the disease, but just a short-term treatment. And the question is, what can we do there? It's very hard at the very beginning to diagnose that disease. It can be stable. That means we have a permanent ischemia of the heart muscle. There's chest discomfort and mainly caused by activity. So if you are kind of overactive, you get it. Otherwise, it works well. Can turn into an unstable one where it changes or worsens. It occurs then unpredictably at rest and might also at the very end lead to a heart attack. So therefore there's a good reason to do something against it. And if you like to do something against something, you should know where it comes from. And the main cause is arteriosclerosis of those arteries that are around the heart muscle and feeds the heart with oxygen and nutrients. So how does this work? We can either have a chronic inflammation there on the artery wall and or have no adequate removal of fatty substances and cholesterol from macrophages. And if this happens, a plaque forms within the arteries. That means there's a piece of something, soft, flaky, yellowish material composed of macrophages, and cholesterol crystals are in the underlying area, and there's a calcification of the outer base, and this hardens the arteries and it reduces the cross-sectional area. That means it's harder for the blood to go through. Right, and so reason for that is, of course, in some cases unhealthy behavior, eating too much fast food, not moving, smoking too much, things like that. On the other hand, there are also some predispositions that certain persons have a higher prevalence of suffering from such a disease than others. This cross-sectional histology there is a very end stage, and normally if it goes slowly, patients do not recognize that. So it's really a sneaking, slowly progressing process where you have some tissues here. And if I get the laser pointer, I can show you here. This is the open area that is still left, and this has been the original blood vessel where the lower part is occluded and the upper part forms a kind of new intima here that is now progreding, getting smaller and smaller. This is shown here. We have a fibrous cap. There are macrophages, there are liquid lipids, calcium, cellular debris. This gets smaller and smaller, the cross-sectional area. And if we have either the rupture of a cap that frees a thrombus, or we have a complete block, then it comes to a heart attack, where the blood flow to the heart is interrupted and the heart cells die due to lack of oxygen. And as already said, hypertension, smoking, hyperlipidemia means elevated level of lipids are root causes of that disease. So, how can things be treated? First of all, best is change your lifestyle, stop smoking, exercise regularly, keep a diet. That's something nobody likes to hear. We can take medication or a surgical intervention. That's called a bypass surgery or a balloon angioplasty with or without stenting. So the very easy and brilliant idea is take a catheter, go inwards narrow, blow up a balloon and expand the artery again. And if the artery does not want to stay open, take a kind of metal cage in there that holds the artery open. So far, so good. That was the idea, and I like to share with you some advantages and disadvantages of the realization of that idea. So the realization of that idea is called coronary stents. So that metal cage was first used in medical practice in 1986. There are stents also for other arteries in the human body, but I like to focus this exercise on the application of the arteries around the heart. They can be kind of self-expanding, so if you have shape memory alloy that expands after a certain time being exposed at body temperature, nitinol, that combination of nickel and titanium, that can be used, or something that is not self-expanding but can be expanded with a balloon. So the length is between 8 and 32 millimeters. The width, that means the diameter, is between 2 and 4.5 millimeters, and the thickness is as shallow as about 90 microns. That means less than 1/10 of a millimeter. So how to bring it in place, that stent? Well, for any catheter in the heart or the stent, placing the stents or widening the arteries, you need a catheter that is mainly placed over the arm artery, or for stenting over the leg artery. And the reason for taking the leg artery is that the curvature of the aorta is better approachable over that leg artery. As you see here from the leg, there's the curvature is, let's say, less critical than over the arm artery. The whole stuff is done under X-ray examination that you see where you are. The stent is pushed forward over the high pressure system of the cardiovascular system, and that means if you withdraw the stent, you have to take measures that you don't have a pulsating blood flow where you die from. So it's not that easy. It's minimal invasive. It's minimal invasive surgery, but that does not mean at all that this is not a serious intervention. So you bring in the catheter and your stent is folded over an expandable balloon. And if you have checked an X-ray that you are in place, that means your balloon and the catheter are over the plug, then you expand the plug. That is something where it takes 2 to 3 to 4 bar. So it's really something like your tire on the bicycle. That takes a lot of force to inflate such a balloon, and to press the stand to the vessel walls and expand the vessel cross-sectional area again. If you do so, you definitely will destroy the surface of the stand and you will free some agents. And you have to take care that those freed agents do not form a thrombus that then eventually blocks arteries in the lungs or in the brain. So far, so good. So, is that all? Are we now safe for our lifetime? So, first of all, to come back to the engineering point or the engineering discipline, we have to see what are these stents made of? What materials do we have? We have bare metal stents, BMS. We have drug-eluting stents, DES. So that means they release something. We have bioresorbable stents. They go after a certain time. Dual therapy stents and bioengineered stents. This is something that I don't want to focus on today. And electronics containing stents, very cool. So you have something that talks to you while being implanted. That's research and not yet in clinical practice. So the bold ones, those three, are approved medical devices that are applied hundreds of thousands of times. So what are the requirements? This is from Admedes, a German company manufacturing stents, and the ideal material, as you see, that's quite a challenge. So it should be strong and flexible at the same time, compressible and expandable at the same time. Durable. Manufacturing should be easy, surface finish should be ideal, should not corrode, biocompatible, should be opaque in radio, that means in X-ray, and CT should be MR compatible, that you can change imaging modalities, and the best will be to have good polymer adhesion, that you can hide the drugs in the polymers. Sounds a bit like a fairy tale. So how do you manufacture stents? It's mainly done by laser structuring. There are wire woven ones, there's mesh stents, but most of them are, to my knowledge, tube stents. That means you take a tube, you take a laser and structure the tube according to your design and get spiral and multi-design stents as shown here, having zigzag lines, having interconnections or S-shaped bandings, and if you go with a balloon inside and expand the balloon, either the connections will break and or the zigzag lines will expand, that you end up in an expanded stent. Everything has to be polished, that you don't have sharp edges there or residues that enhance foreign body reaction of the stents while being in the body. MEMS approaches are rare. You could imagine sputtering of metal layers and etching or lift-off, but the thickness is not that high that you can really use it for mechanical support of those vessel walls. So what materials can you imagine? We can say the usual suspects. So this is a timeline. On the left-hand side are the 1990s, and towards the right-hand side we come to our presence now. We have stainless steel or alloy, which is a nickel-cobalt alloy at the beginning. Then it was the time of nitinol, that nickel-titanium shaped memory alloys, well knowing that nickel might be allergenic. There are woven approaches, there's something like platinum iridium, or we have MP35N, that's also very well known cobalt alloy from cardiac pacemakers that is very corrosion resistant. Or some other alloys depending on the secret recipes of the manufacturers. This is how a bare metal stent looks like. We have those zigzag lines and you have some larger metal pieces, and they're used as radio markers that you can see in the CT, in the X-ray where your implant is. So cobalt chromium alloy or platinum chromium alloys, the scaffolds should open the vessel walls, and if the artery heals after this expansion, the tissue grows around the stent and holds it in place. But it's still there, you know, it's there, and if the artery moves, the stent has to move. But there are problems. What are the problems with bare metal stents? Well, one major problem could be the stent thrombosis. So there's a metal, and this is in direct contact with the blood flow, and if the blood flows over the metal, then the complement system of the blood sees the foreign body and starts a cascade reaction there. That means there's a high thrombogenicity, and we have to check that this does not cause any thrombi that are traveling around the body and block small arteries. And or we have restenosis. That means there's a foreign body reaction, so the body walls out the implant. Cells are growing on top, and if cells are growing on top, the diameter of the artery is decreasing again, forms scar tissue, and we have a new constriction. And this happens in more than a third. So here in more than about 43% of all cases. And this is quite a lot, you know. That's 2 over 1, roughly. So one measure that has been taken is the idea of drug-eluting stents. That means you make structures on the surface of a bare metal stent and put a polymer and hide a drug in the polymer, that the drug is released just by kind of diffusion reactions and interacts with the foreign body reaction, and in the ideal case diminish and reduces that. Question is how to make that work. We need a slow release of the drug to block cell proliferation. If it goes too fast, it's just gone. And therefore we have 3 layers of polymers. One is for adhesion, that the polymer does not flake off the metal. One contains the drug, and then we have a kind of coating of the coating to slow down the release. And this drug release limits the growth of new tissue on the inside of the blood vessel, and the technical term is neo-intimal scar tissue. Neo for new, and the intima is the inner layer of the blood vessel. In Europe, this approval has come in 2002, and this is a combinational product since the stent as such is a medical device, but you also have to comply with the boundary conditions of the pharmaceutical regulations, because there's a release of a drug. Since this takes a certain time, you have to take additional drugs up to 12 months before everything is really stable. Here's another design and a photo storyline to show that the drug is really released from the holes in the stent structure, and after 90 days nothing is left. And if you have those reservoirs, there is no need for surface polymer coating. You can put everything in those holes in the reservoirs, and you get rid of that additional challenge that the polymer should stick to all surface structures. So, non-degradable polymers, however, could cause persistent arterial wall inflammation and delayed vascular healing, and therefore the idea is to coat drug-eluting stents with biodegradable polymers, that we have a combination of controlled drug elution and biodegradation of the polymer, and after all there's a bare metal stent that remains in the artery. That means we have initially the benefits or the advantages of an anti-restenotic standard drug-eluting stance, and after biodegradation we have the safety benefits of a bare metal stent. As third class, there are bioresorbable stents. It's a kind of drug-eluting stent. It's made out of polylactic acid, and the coating has a polymer containing drug. However, also the substrate degrades over 2 years, and that means at the very end there's just the artery left as it is, being more open than it was before, without any cartilage being somewhere hidden in scar tissue. That means we have still vasoconstriction and vasodilatation. That means the adaptation of the blood vessel diameter depending to the physical activity and the need of blood, that is no longer controllable with a metal cartilage inside a blood vessel, where the blood vessel diameter is then fixed to one value. This new thing has been approved in the US in 2016. However, there are still some challenges during implantation, attaching the catheter, recoiling after ballooning. Does the artery get blocked again afterwards? So still some open questions that have to be solved. Research is ongoing also with metals for bioresorbable stents. If you remember knowledge about metals, if you have a noble and a less noble metal and you put them together, the less noble metal will be dissoluted. It's called corrosion. And if you have then the other metal left, that is a not really noble metal, then it gets also diluted in the human body. And if you take, for example, magnesium and zinc, that are also trace elements in the human bodies, you can make a bi-metal layer stent that gets first dissolved due to the different electrochemical potentials of the two materials in contact, and afterwards, when one is left over, then the body takes over its job and dissolves the other one. Dissolution goes slowly. That means the amount of metals is still in the level of trace metals, and no toxicity is around. Another one, these are the latest ones, are bioengineered stents, for example, coated with antibodies, where certain cells are attracted here, for example, endothelial progenitor cells, which are coming from the bone marrow, and they are attracted, they grow over it, and the stent is somehow hidden then under the desired layer of cells. We have healthy endothelial tissue towards the bloodstream. The surface is rapidly recovered, and this reduces the risk of thrombosis. They are still in clinical trials, but not yet approved, and so we have to see when they will come to the market. Dual therapy stents are a combination then of drug-eluting and bioengineered. That means we have they are the latest type in developments. They should enhance the healing process, prevent restenosis, and therefore, on one hand, cells are attracted and drugs are eluted. There are two coatings, one inside, one outside, so very sophisticated mechanisms. Towards the bloodstream, they're coated with antibiotics. Outside, towards the artery wall, they contain drug blocking the inflammation response, and therefore you reduce the inflammation response while the cells grow on the inner surface of the cartilage. So As always, if somebody says it's close to the market, you never know what happens on the last mile. So that's something one has to check out before those things get finally approved and the patient numbers rise. There are many groups. One is from Seoul National University. I know that Northwestern is also working on that. Electronics containing stands. So whatever you can imagine can be integrated into the stand material to control temperature, to control drug release by other modalities, for example, near infrared, also to measure the impedance for tissue growth, and whatever electrical and physical sensor is around, you could imagine to monitor that. The challenge is really to integrate that on a stand wall, to insulate it from the metal, and to make it work on such a small surface and to get energy onto that. In best of all worlds, the electronics is degradable and knows when it should work and when it should start to degrade. Really fundamental research, cool stuff, very challenging from a reliability aspect of work. So with that, I'm through. I think it's now up to you to read through the slides, to take the paper, take some notes, to look through the recordings and the slides of the lecture and the exercise, probably take some additional information at hand, either by the internet or by the help of a textbook. It's always good to check out if your keywords you use for research are good enough. So you can take Google, of course, you can take Wikipedia as point of departure, but I like to invite you to go deeper, for example, into the Public Library of Medicine, PubMed, PubMed. If you type that into Google, you get to the National Institutes of Health Library. That's for free, especially for free, with free access to many journals. If you have a university IP, that means please use your tunnel, your VPN if you are at home, and then you can find very special literature and can check if you're interested what state of the art is and how things really work. And with that, I'm at the very end. Thank you very much. This is now the very last slide. Take care and have in mind that there's another test 4 on Wednesday, July 22nd. We'll cover exercise 5, lectures 8, 9, and 10. Wish you all the best. And if you have questions afterwards, do not hesitate to drop them in the question and answering sections of our Ilias system, or send me an email and I'll try to respond in time. Thank you very much and goodbye.